Hello everyone, and welcome to the first section of patient assessment. This is entitled Heart Rate and Respirations. As always, this is Keith Whitmire with Wayne County EMS. Let's go ahead and get started. Start out with baseline vital signs. Baseline vital signs are an initial set of vital sign measurements against which later measurements can be compared. Watching these trends in your patient's condition is very important. With this information and your patient assessment findings, you will be able to recognize life-threatening emergencies such as shock. To take a patient's vital signs, you'll need a watch with a second hand or digital watch that shows seconds. The watch will be used to count your patient's respirations and pulse. A pen light or flashlight. This will be used to look at your patient's pupils. A stethoscope. Stethoscope is an instrument used to hear sounds within the body, such as respirations. It's also used to measure blood pressure and listen to heart tones. A blood pressure cuff, known as a sphygmomanometer. This is used to take a patient's blood pressure. And a pen and paper to record your findings. Arteries are large blood vessels that carry blood away from the heart to the rest of the body. Blood is forced into the arteries when the heart contracts. A pulse is the rhythmic contraction and expansion of these arteries with each beat of the heart. A pulse can be felt anywhere an artery passes near the skin and can be pressed against firm tissue such as a bone. Central pulse is a pulse found close to the trunk of the body. Examples of central pulses include the carotid pulse and femoral pulses. The carotid pulse is the major artery of the neck and supplies the head with blood. Pulsations can be found on either side of the neck. To find the carotid pulse, place your index finger and middle finger in the soft, hollow area just to the side of the patient's windpipe, the trachea. What you'll do is if you just go right on midline, right where the trachea is, and you come halfway down, you should be able to palpate a pulse. The femoral artery is located in the fold between the thigh and the pelvis. In this field, a femoral pulse is not often used because the patient's clothing prevents easy access to the femoral artery. To adequately feel a femoral pulse, you may have to apply more pressure than is required at other sites. This may be a common site to assess pulses during cardiac arrest. A peripheral pulse is located farther away from the trunk of the body than a central pulse. Peripheral pulse is felt at several locations. The radial pulse is located in the wrist at the base of the thumb. Check a radial pulse first when assessing a responsive adult or a child greater than 1 year of age. The brachial pulse is located on the inside of the upper arm, midway between the shoulder and the elbow. Always check for brachial pulses in an infant. The posterior tibial pulse is located just behind the ankle bone, and the dorsalis pedis pulse is located on the top surface of the foot. Excuse me. To feel for a pulse, use the pads of your index and middle finger and apply gentle pressure to the artery. If you use too much pressure, you'll cut off blood flow through the artery and will not be able to feel a pulse. Count the number of beats for 30 seconds and multiply the number by 2 to determine the number of beats per minute. If the pulse is regular and your SOPs and protocols allow it, you can consider counting the amount of beats in 10 seconds and multiplying it by 6, or counting the amount of beats in 15 seconds and multiplying it by 4. If pulses are irregular, you will need to consider palpating a pulse for a full minute. Patient's pulse rate varies with age and physical condition. When checking a pulse, note the pulse rates feel very slow, very fast, or within normal ranges for that patient's age. Also note if the rhythm of the pulse is regular or irregular. In newborns to 1 month, in the newborn age range, which is birth to 1 month, pulse rate should be approximately 120 to 160 beats per minute. In infants, ages 1 month to 12 months, pulse should be 80 to 140 beats per minute. In toddlers, age 1 to 3 years, pulse rate should be 80 to 130. Preschoolers, 4 to 5 years, should be 80 to 120. And school-age children, 6 to 12, should be 70 to 110. Adolescents and adults should be 60 to 100. Possible causes of slow heart rate include coughing, vomiting, straining to have a bowel movement, heart attacks, head injuries, very low body temperature, hypothermia, sleep apnea, or some medications. The coughing, vomiting, and straining to have a bowel movement may stimulate a vasovagal response, which is one means to drop a blood pressure. Other considerations, so like it says some medications, particularly beta blockers. If you look at a patient's medications and it ends in LOL, it would be safe to assume that that is a beta blocker and the heart rate may be low. Possible causes of rapid heart rates include fever, fear, pain, anxiety, infection, shock, heart failure, substances such as caffeine or nicotine, cocaine, amphetamines, ecstasy, cannabis, or other uppers, and some medications, as well as exercise. I can assure you, my fat butt on a treadmill will have a very fast heart rate. Pulse quality refers to the strength of the heartbeat felt when taking a pulse. Normal pulse is easily felt, and the pressure is equal for each beat. This kind of pulse is said to be strong pulse. A pulse is said to be weak if it is hard to feel. A pulse that is weak and fast is called thready. Pulses are normally equal strength and on both sides of the body. To count the patient's respirations, place the patient's arm across their chest or abdomen. Hold the patient's wrist as if you're assessing the radial pulse. Watch the rise and fall of the chest or abdomen. Begin counting when the chest or abdomen rises. Count each rise and fall of the chest or abdomen as one respiration. Watch to see if respirations are regular and if the chest rises equally. Count respirations for 30 seconds. Multiply that number by 2 to determine the rate for 1 minute. If the patient's respirations are irregular or slow, count the rate for a full minute. When counting respirations, you really cannot go by 15 or 10 seconds. The minimum that you can do is 30 seconds. In infants and young children, it is often easier to observe the rise and fall of the abdomen to determine the respiratory rate. Count an infant's respirations for a full minute. Excuse me. Respiratory rates vary with age, just as heart rates. Newborns are 30 to 50, infants are 20 to 40, toddlers are 20 to 30, preschoolers are 20 to 30, school-age children are 16 to 30, adolescents and adults are 12 to 20. Normal respirations are evenly spaced and of adequate depth. Infants and young children tend to breathe less regularly than adults do. Irregular respirations may be associated with conditions such as diabetic emergencies or head injuries. A patient is said to breathe shallowly if it is difficult to see movement of the chest or abdomen during breathing. Only a small volume of air is exchanged during shallow breathing. Normal breathing is relaxed and effortless. Labored breathing is an increase in the work or effort of breathing. If the patient is having difficulty breathing, he is usually irritable, anxious, or restless. He may see gasping for air, excessive widening of the nostrils with respirations. This is referred to as nasal flaring. Use of muscles in the neck to assist with inhalation. These muscles are the sternocleidomastoid muscles. You'll notice utilization of those muscles as well as abdominal and intercostal muscles. Sinking in of the soft tissue between and around the ribs or above the collarbones, known as retractions, and skin color changes. Normal breathing is quiet. While counting the patient's respirations, listen for any abnormal respiratory sounds. Abnormal respiratory sounds include stridor, which is a harsh, high-pitched sound like the bark of a seal. You can listen to this as well as the rest of these sounds in the airway section. If you click onto the lung sound directory, there's a wave file for each of these sounds. Stridor is associated with severe upper airway obstruction and is most often heard during inhalation. Snoring, which results from partial obstruction of the upper airway by a tongue. Wheezing, which is a high-pitched whistling sound heard on inhalation or exhalation that suggests a narrowed or partially obstructed airway. Gurgling, which is the sound heard, back on wheezing, that generally suggests a narrowing lower airway. And gurgling, which is the sound heard as air passes through moist secretions in the airway, generally upper airway. And crowing, which is a long, high-pitched sound heard on inhalation. This concludes the first section of assessment, entitled Heart Rates and Respirations.